This is the fifth in a set of 6 masterclasses provided by Phoenix-Aragon Education and presented by Ana Aragon.
Hello, we're delighted to welcome you to this recording of an educational session exploring Parkinson's from the perspective of all healthcare professionals. This online event was streamed to an audience of occupational therapists in autumn 2020. Tonight's session is based on a region of the map of Parkinson's that I created to try and sort of help to pull together all the ideas that people would find they needed to learn about in Parkinson's disease. So tonight we're looking at the neuropsychiatric symptoms, and we're working through all of these different topics over the next several minutes. So thinking first about mental health, so neuropsychiatric, you could call it mental well-being, but we've called it neuropsychiatric symptoms. But one of the known symptoms associated with Parkinson's can be depression. And actually, even before the start of the condition, in terms of motor symptoms can be observed and there's a diagnosis made. Depression may well be a feature in people's lives years, several years or 5 or even more years beforehand. So a pre-existing history of depression is you could say a risk factor for Parkinson's, or perhaps it's just a symptom of this very, very slow, insidious condition that slowly progresses, and it may start in the domain of mental health. So I think thinking on about other things that can start at this stage is anxiety, and often comes together with depression, and then possibly also with panic attacks. And this is something that can happen both within Parkinson's once the condition's been diagnosed, but also again as one of these early what we call prodromal symptoms, some of these non-motor symptoms that assail people gradually, insidiously, a bit like sort of going grey over a very long period of time. But as you know, anxiety can also be associated with panic attacks, and it's not unusual for people with Parkinson's who are actually diagnosed with Parkinson's and taking their medication as a sort of routinely prescribed to start to get actually sort of this on-off fluctuations with waves of anxiety that build as doses of medication wear off, and then the anxiety builds up, and then another dose of medication is taken, and once that dose kicks in, the anxiety reduces, the mood goes right up. And one of the things you see in a Parkinson's clinic, if you get that extended time period with your patient, which you're not going to get in a Zoom meeting or in a in a short clinic appointment, but if you can see people over a full drug cycle of like 3 to 4 hours or something like that, you can see them go through this cycle of anxiety and panic and can't transfer, can't walk, and mind completely alert and racing, hyper alert in a very stressed out state. And then the dose of medication is taken, and then this same individual within half an hour, they've completely chilled out. They've just become themselves again. The anxiety has diminished, and then during the on time of the medication dose, this anxiety is a distant memory, quite honestly. And it does actually dawn on me quite often when I look at research and you look at these rating scales and you sort of think, well, what stage in the medication cycle were you at when you rated your PDQ 39, or you rated whatever scale it was? Because are you in exactly the same phase of your medication scale when you repeat that measure? Because if you're comparing an individual score to itself and you measured people just like an hour and a half apart, you could get very different scores on some of these anxiety and depression scales and those kind of things. So one of the things, if people are sort of on their medication for Parkinson's, is a medical review. So I've got a reminder up there, and it's quite useful to consider if people are getting this kind of waves of anxiety through the day as their medication levels dip, then looking at these more sort of steady delivery systems where people are having more long-acting doses, and then they can find that their mood doesn't become subject to these kind of afflictions, I suppose you should call it, really. It's something awful to live with. And before I move on from this slide, actually, I did recall reading somewhere that this sensation of anxiety, which is a very physical sensation to people when it's actually happening, is perhaps the manifestation of dopamine starvation at the synapses, and the way that we feel that starvation of dopamine where it's needed deep in the brain is through this panic of anxiety. So that kind of completes the circle of why the medication would be a useful strategy to consider. But then there's sort of actually the education side and helping people develop a bit of insight. And that's relevant with some of the other things we'll be considering. And we'll talk more about management and teaching coping strategies and things in our questions and conversation later. So moving on, we're sort of doing a whistle-stop tour tonight of neuropsychiatric symptoms, and hallucinations is one that I wanted to dwell on a bit now. So common themes for hallucinations in people with Parkinson's can be around animals and people, children, miniature people, miniature animals. But then there's some other sort of themes that can come up. And it seems that all of this stuff, when it's in people with Parkinson's disease, can be around the medication use, although there are some cases of people having this early in the disease, perhaps when they haven't used medication a lot. But it tends to be a sign that someone's going to probably go into the mild cognitive impairment and a dementia type Parkinson's if they do have hallucinations early in the condition. But sometimes these things can come without any kind of thought disorder, just as a visual effect generally. Hallucinations in Parkinson's do tend to be visual. In other conditions like schizophrenia, they tend to be more auditory. But in Parkinson's, sort of things patients will talk about is things like, you know, what was it? My son in the houseplant in the corner of the room, and very strange stories about 3 prostitutes on the sofa. When I was on a home visit, I wasn't allowed to sit on the sofa because it was occupied by these 3 women. I've always been fascinated to think how they were dressed, because the patient sort of like, you know, told me to sit elsewhere because the sofa was already occupied by these women. But it seems that hallucinations can actually follow the pattern of dreaming. So in 90-minute cycles through the waking day, episodes of hallucinations tend to be recorded. And it follows the pattern the same as those 90-minute cycles for dreaming sleep in the night. And some people find it is a drug responsive symptom, so that the higher the medication dose in terms of perhaps management of motor symptoms, so suppression of bradykinesia and tremor and things, then they'll tend to get this elevation of hallucinations. So there can be a little bit of a juggling act, and some people actually can have quite good insight into their hallucinations and not be distressed by them and actually tolerate them. And I think in the question and answer bit later, we'll talk about this, but I've certainly encountered people who for several years, with good support from the clinic of checking in on you know, how's it going and what sort of thing are you seeing, and sort of, you know, validating their experience, but also acknowledging that it is hallucinations and it's a side effect of the medicine, and they're making you dream when you're awake, and giving that sort of rationale to it. People can kind of tolerate it to quite a surprising amount. But on the other hand, when there starts to be ideas around these things, then we can get problems. And reading through this screen, I could remember someone pointing out the window at the cows on the roof yonder, and it was chimney pots rather like this. And I can kind of see how he saw cows on those, you know, those legs there on those chimney pots, but that's like an illusion, that's a misseeing. And then the car headlights. So there was a man in a cottage on a lane, and he got the idea that children were playing with torches in his back garden, and he was very disturbed. He was very elderly. It was quite a problem at night time. But what it turned out, it was the road behind the garden, the lane came down, and it was the headlights of cars, the occasional cars in the night that were driving down that lane, that were shining into his window. And then he was misinterpreting it, and he was searching in the garden for these children. And it was the hallucinations had become delusional as well. And then there are some odd things that people have talked about. Double worlds. I don't know, I'd love to hear later from anyone who's come across this, but people have told me about this thing where as they go through a doorway, they have to choose whether they're going into the real living room or the other living room. And the same gentleman told me he had 7 toilets. Now he had 3, but this duplication syndrome, as it's called, has been written about in, if you read up on psychiatry and mental health, there is something called duplication syndrome. And there is also something that this fish, you see this picture of this insane fish here. Now, a patient described this to me, and she had hallucinations without delusions, in fact, but it was certainly an illusion. So she told me that she was being followed around by a man who was wearing trousers from the waist down and a fish from the waist up. And she knew it's a hallucination, and she was kind of tolerating it just about at that point when she described this to me. So some people, they get into this sort of delusional things. There was someone, they told me, on the ward in inpatients, he had Parkinson's, he was waking up on the ward, and there were people in Victorian nightgowns leaning over him and then following him everywhere he went around the ward. And we suggested to him this was hallucinations. And after several days, he sort of came back on this conversation and said, you know, I think you must be right, because the NHS isn't going to spend money on actors to actually come and follow me around like this. You really must be right. This is hallucinations. This is not really actors that you're employing to follow me, which is what he thought at first. He really thought they were members of staff that were watching him. And then you can get into these things where people do get paranoid, and they think their neighbours are listening through the walls, or that the TV is listening to them, or whatever. A lot of delusions can cause problem in close relationships, where an individual with Parkinson's thinks their spouse is having an affair with the doctor who's managing the Parkinson's because of the frequency of the visits to see said doctor. Or a supportive neighbour or someone like that. There's these delusions of infidelity that can be quite a strong theme that goes on for some people, and can be very difficult, you know, for people in work situations who are getting problems with this. Imagine trying to sort of fit in when you're having hallucinations or delusion. The man with the money being shaken out of him was a particular patient I recall who, again, he was very delusional, and he had the idea that there was light coming up from between the floorboards upstairs in his house, and he would spend a lot of time on his hands and knees looking through the gap in the floorboards because he thought there were men inside, miniature men in the space between the ceiling and the upstairs floor. And he also had this big worry about the tax man and how the tax man was going to be after him. And every time the doorbell went, he thought it was the tax man coming to get him. So people get very stuck into some very strange ideas. And then down in the bottom corner, this is the picture of the twins there, is to remind me about mentioning to you about Capgras syndrome, which is a delusion that people are imposters, a delusion of substitution. So it's particularly a condition that affects relationships that are very close with an individual. So a spouse, a sibling, a parent, whatever it is, a child, may be perceived as an imposter. It's a very strange condition. It particularly occurs when there's visual input involved. So say a lady living alone with Parkinson's gets a phone call from her daughter, and that goes fine. And then the daughter says, I'll be popping round in an hour. And when that daughter turns up on the doorstep and the lady opens the door, she looks at the daughter and she says, oh, you're not my daughter, you're an imposter. You're pretending to be my daughter, you're not really my daughter. So what's actually going on in this is called Capgras syndrome. So it can cause quite a problem with in Parkinson's. It does occur sometimes. And what's going on is that when you perceive the face of a person that you know well, you have a visual memory of that face, so you recognize the face. And then from a separate part of your brain, you get this emotional memory that's goes with the recognition of the face. And these two signals come together. And in Capgras syndrome, those signals don't come together. So you see the face, but you don't get the feeling from the face. And therefore, you work out that the face isn't really that person because it doesn't feel like that person. So it's a degeneration of a part of the brain that stores this emotional memory that causes this discrepancy between seeing an individual you know well and then saying, no, but it's not really you, you're an imposter. And then when they go back on the phone, they go round the corner into the back garden, they ring up and say, Mum, look, it's really me at the door, just let me in. Oh, yeah, that other girl, she was here. Come round now, quick, I'll let you in. And the same thing happens again. As soon as she sees the face, you're not the daughter. So all of these sorts of things can be things that are going on in the kind of the daily lives of people with Parkinson's. And as you can no doubt realize from the sort of stuff I'm talking about, this causes great disharmony, shall we say, in day-to-day life if it's not understood and not well managed. So moving on to even greater disharmony, I suppose, really, is the subject around compulsive and repetitive behaviours in people with Parkinson's. So there's a system within the brain where dopamine feeds motivation to take action, to do an action, which is then rewarding because you get the result of the action, and that reward is motivating and generates the loop to go round again. So when we medicate people with Parkinson's, particularly with the dopamine agonists, but with all levodopa or dopamine-raising drugs, you can get this problem where people go into that cycle of repetitive behaviour and it turns into this very tight loop, and it can be expressed in a variety of ways. So in the background, if you can just focus in a minute, you'll see there's a load of buttons. So a very benign form of compulsive and repetitive behaviours is sorting. And I was shown a film at a conference, right back, maybe Claire saw this as well, of a lady sorting buttons at night. And she had these little Ziploc bags and she was sorting them by colours and sorts and separating them out into little groups. And someone had asked this patient, what do you do at night? Apparently is the screening question for this. What do you do at night? And this comes up with some of these other themes as well. And this particular lady was sorting buttons, and then there was, I think, another one, or the same individual, she was making freezer labels for all these things she might want to freeze. She was writing out these labels with a pen all night. And this is called punding. This is compulsive, repetitive, meaningless activity. They say it's meaningless, but to the individual, it's not quite meaningless. But that's the very benign end of it. So compulsive behaviours can also be in the form of eating, shopping, but even more sort of problematic can be in the form of gambling, which of course now is easily available online, so that's 24 hours a day. A lot of people get into lots of financial difficulties quite secretly and quite under the radar of some Parkinson's clinics. I remember a Parkinson's nurse wrote an essay, and I was marking it, and it was about 7 years this man had been attending their Parkinson's clinic for 7 years in England, and they were a Parkinson's specialist clinic, and no one had ever asked the question, have you noticed any change in your behaviour since you started taking this medication? Which I think is kind of a trigger question for sort of trying to pick up on this. And finally they asked the question, and by this point he had done all those things. He'd brought the prostitutes home to the family home, he had spent all his money, fallen out with his lifelong business partner, he'd bankrupted the business, he'd moved out of the family home, he'd got divorced, he was living in a bedsit, and then someone asked the question, and he was on far too much medication. And I just couldn't believe this, you know, tragedy really of someone being neglected like that, really, in terms of not monitoring the response to medication. So there's a picture down in the lower right corner to remind me to talk about Avanzi. What was it called? The Joy? I think it was The Joy of Reckless Driving was his publication. So he was an Italian neurologist who published something in 2004 about people who are in very high dopamine state with their medication for Parkinson's, going out joyriding at 150 miles an hour on the M25 all night, going round and round and round as fast as they can go. And you do hear occasional news reports of those people going the wrong way on the motorway. Quite often they have Parkinson's and they've gone out and they're doing this reckless driving, and this is again one of these compulsive and repetitive behaviours that can occur. So what we need to do is make sure that at every review there's someone in the team at some point is going to screen for whether there is any problem behaviours going on, because if they are, certainly then a medical review and a trimming down generally of medication. I mean, this can become a thing when people have DBS surgery for Parkinson's. If they don't have the medication reduced, you can push people into this as well through too much stimulation of that region of the brain. So moving on to delirium, what a place to go. So in Parkinson's, you may well see the sudden onset of a very altered mental state. And that could, often in people with Parkinson's, can be related to an infection of the chest or the bladder, or even a wound that isn't being cared for by an individual, that they're not managing their self-care very well, and perhaps they've neglected to notice an injury. So quite often there's a septicemia of some sort, or sepsis. So if there's a sudden onset of sort of, a very big change in conscious state, then, obviously screening for infection and a medical review is important. So trying to ascertain whether some of the things I've been talking about earlier are part of Parkinson's, or whether they're acute infection is part of the skill. And actually, if you look at reasons for admission to hospital for people with diagnosis of Parkinson's, the most common reason for admission in the United States was psychosis, whereas in the United Kingdom it was the infections, it was the bladder and chest infections were the main precipitating causes to people getting admitted to hospital in this country. And it suggests differences in the way the health insurance company works. So in the United States, your infection has to then drive you into psychosis and delirium before you get admitted. Whereas in the UK, you can get admitted more with the consequences of the infection. And of course, falls can be related to this as well. So it's important for people's mental health to be on the radar at all times that we're interacting with them, really. In Parkinson's disease, specifically, the combination of the hallucinations and the delusions, basically hallucinations plus delusions equals psychosis. If it's not an acute confusional state, which is more the sort of what we just said just now, the delirium and the sepsis and things, and generally people need quite urgent intervention at this point. So anyone who comes across people who are clearly moving into another dimension, it's obvious to other people when people get this unwell, but we hopefully we're scanning for it, but it doesn't always happen. And in Parkinson's, sometimes in more advanced Parkinson's, you can get issues when people are being over medicated and they're basically being pushed towards psychosis through the dopamine levels that are now too raised for their metabolism as they've aged and their heart function changes and things. When you get into advanced old age, your blood pressure starts to fall again after it goes up and up and up. I think it reaches some peak in your 80s. If you get into your 90s and late 90s, the whole need for medication may be quite less, and people sometimes move into a nursing home setting on a fixed dose and no one ever really reviews it anymore. So over time they then become over medicated and they get psychotic. Again, from these essays, this was a physio followed up a Parkinson's patient who'd become too mentally unwell, so too psychotic to attend physio Parkinson's exercise classes. So she did a study for her master's on, well, what happens to these people's activity levels? I'm a physio, I specialise in Parkinson's. When I discharge them because they can't make it in the transport and they can't cooperate in the group anymore. So she went to visit this man at home, and he was in a nursing home, and he was locked in with one of these wandering alarms on the nursing room bedroom door that was kind of monitored down in the office, but it was kept locked. It was an electronic lock on his bedroom door because he was wandering and being sexually inappropriate with the other residents. And he was clearly well over medicated. But no one had spotted this. They just spotted his out of order behavior, inappropriate behavior, completely wrong conduct on his behalf, fair enough, but they were dosing him up with all this medication every day. So once the physio went to visit, she said, "Oh, do you think that perhaps this person needs to have their medication reviewed?" Because the physio had been studying Parkinson's for 4 years by this point, and had much more insight than the people who were running this nursing home. So we can get these problems. And actually, if you talk to an individual in this situation, and you can, talk to them in a calm space and stuff, and in a reassuring way, people generally would rather be less mobile in exchange for being less mad, so more sane. And that tends to be the trade-off at this stage in advanced Parkinson's, of people being made delusional and psychotic by their medication on a regular basis, and it's causing them distress and those around them distress. The medication needs to be tailed down and perhaps removed altogether for some people, but that has to be done gradually. And you can reach a level sometimes where you can bring the medication down and they get the sanity back, but they've paid in the price of mobility, so the mobility is much worse without that kick of the medication. So the rigidity becomes more, the tremor becomes more, the slowness is greater, but their mental health is improved enormously, and you can switch people back from that kind of insanity, delusions, trying to rip up floorboards. You can turn all that off by bringing the medication down. These things, you just need to reach out to people, get their medication urgently reviewed if you come across this kind of thing, and just have it on your radar that this. Sometimes I think this is one of the disadvantages of this remote working. I've been watching loads of sessions at the Movement Disorder Congress on video working, and this wonderful Nigerian doctor who swapped her clinic to a mobile phone system. It's amazing what people are doing. But if you're talking to people as a couple for a distant call, sometimes these sorts of things won't come to your attention unless you're in a face-to-face situation, or at least a one-to-one situation. So sometimes people have said things like, if they're having a Zoom consultation with the patient, there's another one is problems around sexual well-being. Patients often don't want to discuss on a video call. So at the end of each video appointment, the patient is offered, "Would you like to meet in person or back online next time?" But also giving people the opportunity that, you can phone me if there's anything else that comes up that you want to mention, and perhaps giving partners and spouses the opportunity to contact you as a therapist directly if there's mental health problems, but they're not able to discuss it with the patient in the room. So you might need to think about that if you're suspicious that there could be issues around this matter, because normally in face-to-face practice we get those moments, don't we, on the front path by the gate or outside of the ward in the corridor, those moments that you get, but you're not going to get that when you're working indirectly with people. So just finally thinking about dementia and memory failure in Parkinson's disease, so that the usual kind of suggestion is that the majority of people with Parkinson's do eventually develop some form of mild cognitive impairment, and eventually that gets to the point where you could call it dementia. But the dementia can be quite a moderate sort. Mild to moderate memory failure is what they tend to say goes on. So there's a lot of memory changes in Parkinson's disease that are actually more of a mild cognitive impairment than a dementia. And that's around very specific sorts of memory. So people are very good at sort of concrete memory and memory that's associated with some visual stimulus, but memory that they've got to retrieve through recall from in their mind with no external trigger is the type of memory that can become a problem. So recognition is good, recall is bad. And when in laboratories they test this sort of thing in people with Parkinson's, they do those tests where they put a load of items on a tray, an apple, a mobile phone, a comb, a pen, a watch, whatever, and they tend to put them on a tray, and then you've got to memorize the objects. And then they represent the tray, And people with Parkinson's can, you know, memorize the thing. Was this on the tray before? Yes or no. They'll do fine with that sort of thing because they've got a visual cue to see an object. But if you give them a memory task where it's, you know, remember, what was it, 42 West Street or something, where they've got no visual external reference point to that, they find that very difficult to retrieve information without an external visual prompt. So everyone gets some sort of level of changes in their memory as they grow older, and that can just be memory failure. In Parkinson's, we get this very specific uncued recall problems, but with cued prompts. So this is where the cue cards and little reminders and the planners and the daily jotters and all these kind of charts and things that we can encourage our patients to use to structure their day, managing their medication, you know, getting the most out of their on time, all those sorts of things. It's very good for people to have external visual ways to organize their day and their routines, and that will help tremendously. But if people are going on to develop more significant problems, we've got the lady making a cup of tea, even there, you know, a cue card, a reminder of the processes. People with Parkinson's can function quite well with that kind of change to their memory and that mild cognitive impairment level. They can sort of cope like anyone would do with that little bit of adapting. But then, you know, sometimes people, the memory failure is getting more significant, and then it'll start to be problems with short-term memory loss, and particularly remembering names, so nouns, so the names of objects. So they'll reach for the thing with the water in it, but I can't remember what the thing is called. So they know what the object is for. So there's no problems with, as you would see in people with memory failure, where they say they've got Alzheimer's, where perhaps a response to being handed a cup might be to turn it upside down to try and work out what it is. A person with Parkinson's doesn't get that sort of memory failure. They just can't name the object anymore, but they know what it's for. So the concept of the object is retained, but the name of the object may be this word finding problem. And the way you pick it up on testing is those tests where you get people to name as many animals as they can in 2 minutes, or as many words starting with a letter, whatever, in a minute. I think they do it now. They don't even give them 2 minutes anymore. They used to give them 2 minutes, now they give them a minute. But those kind of very specific word finding problems are the sorts of problems that you'll tend to see in people with Parkinson's dementia, developing this dementia. You've got more advanced problems you would see if it turns into this Parkinson's kind of dementia with Lewy bodies, and then you start to debate whether they had the dementia first or the Parkinson's first, and then you go into the Lewy body dementia with Parkinsonism if the dementia starts before the motor symptoms. But whether all these things are part of a continuum remains to be seen, because it turns out that Lewy bodies develop in the gut and migrate up through the vagus nerve to the brain. When we were talking about diet and probiotics and prebiotic foods and that sort of thing the other day in an earlier session on the autonomic system and the gut, you know, all of these things link together with mental health as well. It's a wonderful global group talking about the gut microbiome and mental health, and how these cascades of Lewy bodies develop in the lower gut, in the colon. Got these alpha-synuclein inclusions, which are the Lewy bodies, that are these destructive bundles of toxin inside the cells, and the gut's lined in nerve cells all the way through. There's like a lining of neurons, more neurons in the gut than in the brain. So all of these things are connected, and that there's a lot going on there. So whether the people with Parkinson's, they say about 85% of people with Parkinson's develop dementia within 20 years of diagnosis. But I have met that other 15% who've been diagnosed over 25 years and they're cognitively normal. They're slow, they're super slow, but they're cognitively intact in terms of their memory, their reasoning, with the cued recall, with the sort of time to concentrate and attend and have a conversation. And they haven't got any dementia at all after 25 years or more. And I'm sure others of you who've come across this, that you will meet this cohort of people who haven't got any dementia at all, but they're also probably the ones who didn't have much of this hallucination problems that we were talking about earlier tonight, because the hallucinations and the vivid dreaming and the REM sleep behaviour disorder that we talked about in the first session, will tend to be things that will suggest that dementia is going to develop probably sooner in those individuals than in the average. And then, but notwithstanding that everyone won't get dementia, in my opinion, not everyone gets dementia. But that's just in my experience. And other people maybe say, well, they haven't lived long enough yet. But I think that kind of 85% after 20 years have got signs of dementia is a pretty standard kind of figure. Thank you for your attention. We trust you found this session interesting and that you'll make time to view other recordings in this 6-part series.
To find out more about a Map of Parkinson's app and a Map of Parkinson's course for healthcare professionals, please visit phoenix-aragoneducation.uk.